I am pleased to introduce the closing keynote session, Caring for Refugee Families in Calgary, A Decade of Turbulence and Tenacity, with Dr. Annalee Coakley. Dr. Coakley is a Queen's University medical graduate, has committed her career to providing compassionate care to marginalized populations, particularly the refugees who live in Calgary. As the medical director of the Mosaic Refugee Health Clinic, she advocates locally and internationally for her patients' rights and access to health care. Dr. Coakley's journey began in Ontario and in Nova Scotia, where she practiced family medicine in remote communities before settling in Calgary in 2008. A staunch advocate, Dr. Coakley played a pivotal role in reinstating the interim federal health program for refugees and spearheaded initiatives to support Syrian refugees in Calgary. Amid the COVID-19 pandemic, she led efforts to manage outbreaks in the Cargill meatpacking plant and advocated for prioritizing vaccination for vulnerable workers. Her leadership resulted in high vaccine rates, notably achieving a 99% uptake in Northeast Calgary. Dr. Coakley's contributions extend beyond clinical practice as she co-chairs the National Newcomer Navigation Network, chairs the North American Refugee Health Conference, and collaborates with the World Health Organization on refugee health initiatives. Recognized for her dedication, she has received prestigious awards, including the American Medical Association's Compassionate Physician Award and the Queen's Platinum Jubilee Award. Welcome, Dr. Coakley.
Oh my, thank you. Thank you so much. And thank you for the invitation to be here. It's my pleasure. I'm just first going to try to share my screen. Bear with me. Okay, and now. Let me just go to slideshow. There we go. Is that visible, Paula?
It's perfect. Thank you.
Okay, awesome. So I'm Annalee Coakley. I've been the medical director at the Calgary Refugee Health Program for since 2012 and have been working with refugees since 2009. It's been a very interesting journey for me, and I'm happy to share my experience with you today. And so today we'll be talking about caring for refugee families resettled in Calgary since 2012, a decade of tumult and tenacity. And so we'll be reviewing some of the tumultuous times that we've had over the past decade or so. I know that every time we have a bit of a, there's usually a new challenge. The first few times we had a challenge, I thought, well, we'll just buckle down, get through this, and then we can rest. But it's just been a challenge after a challenge after a challenge. And so I've come to realize that's just the nature of the business. And so I just wanted to take the opportunity for a land acknowledgement, because like our refugees, our Indigenous peoples have been forced away from their lands, from their culture, from their communities and families. And so historically, I work in Calgary, and this is the traditional territory of the peoples of Treaty 7 region in southern Alberta, which includes the Blackfoot First Nation tribes of Siksika, Stoney Nakoda First Nations tribes of Chiniki, Wesley, and the Tsuut'ina First Nation, Pekunai, Bearspaw, and Kainai. And the city of Calgary is also the homeland to the historic Northwest Métis and to the Métis Nation of Alberta Region 3. I don't have any conflicts of interest. We will be reviewing sort of the global refugee context and resettlement trends globally, the Canadian refugee resettlement program and refugees and their healthcare needs, the evolution of refugee health services in Calgary and Canada. We'll talk briefly about some examples of both challenges and successes in achieving health equity for refugees in Calgary and Canada, and how we might go about ensuring health equity for refugee families in your work. And so just a bit of a background. In terms of refugees, I'm often asked what a refugee is. And so just a reminder, a refugee is someone who's been forced to flee their homeland for reasons of persecution. So persecution based on political affiliation, based on their ethnicity, based on religion, sexual orientation, gender, etc. And so it's not people who've been forced from their land because of a natural disaster. It has to be for reasons of persecution. And since this is a conference or a meeting on children, it's important to understand that almost half of any refugee population is children. So normally with refugee populations, it's around 41, 42%. And this is a disproportionate because children make up 30% of the world's population, yet 41, 42% of refugee populations. And globally, if you're listening to the news, this is a growth industry. Our refugee numbers are growing every day. And right now we're, beyond, we're 35.3 million refugees displaced across borders across the world. And again, if you just listen to the news, you know where they're coming from. They're coming from places of high conflict in the world. So that's places like Syria, South Sudan, Afghanistan, and Venezuela. And most refugees are resettled or not resettled, but they're living temporarily in host countries. And those host countries typically are the countries that border the countries from which refugees are fleeing. So those are typically, it's Turkey, Colombia, Uganda, and Pakistan host the most refugees. So it's often countries with some of the least resources, such as Uganda, who host very large numbers of refugees. And in Canada, the number of refugees resettled in Canada, so whether they're convention refugees or asylum seekers, those numbers are growing every year. And in Canada, our receiving provinces, so their refugees are resettled across Canada as permanent residents, and the provinces where the highest numbers of refugees are resettled are Ontario, Quebec, Alberta, and British Columbia. And who does the Canadian government choose to resettle? So the Canadian government prioritizes women and girls at risk, survivors of violence and torture, those in need of family reunification, those with high medical needs, and this includes developmental disabilities in our children, and children at risk. And so just because of our selection process, it's obvious that our refugees and our refugee children coming to Canada have high health needs. And Canada has really been a global leader in refugee resettlement. Until recently, Canada has been unique in that it has a private sponsorship program for refugees. And that was quite unique and special in the world until recently when the Americans adopted a similar program. So it's just been launched maybe 1 or 2 years ago in the US, a private resettlement program. So refugees come to Canada, either as government sponsored or privately sponsored, and that's quite unique in the world. And Canada has really allowed since the 50s, since the end of World War II, we've really been a key player at resettling refugees globally. And so starting with the Hungarian resettlement in 1957, all the way to most recently with resettling over 40,000 Afghan refugees, and of course, hundreds of thousands of Ukrainian evacuees. And so it's something we ought to be proud of as Canadians. And so what does refugee health equity mean? It means leaving no one behind, both here in Canada and abroad. So our health services, our health interventions, our health system needs to be accessible to all. So my particular patient population that I serve is refugees. And so we need to build a health system that allows our refugees to meet their health needs. And I often hear from different people. I mean, I live in Alberta, which tends to be a fairly conservative province, and a lot of people talk to me about, refugees and why do we allow so many refugees into Calgary? And they seem to insinuate that refugees are bringing diseases into the country, et cetera. But that is not true. Refugees themselves are not, they don't carry disease as an innate quality into themselves. They are subjected to conditions in their flight from persecution. They're subjected to living conditions which put them at higher risk of communicable diseases and trauma. And so it's just important to separate the person, the human being, who is the refugee, and the conditions to which they've been exposed that put them at higher risk of different illnesses. And so I just like to remind people about the trajectory, the life's journey of refugees and why they have higher health needs. And so oftentimes, people are living in their home country. Usually people who are forced to flee are not the elite of those countries, although Afghanistan is an exception, because that most recently it was their elite that was forced to flee. And so they come with a different set of issues than perhaps other refugees. But typically, talking in broad strokes, the people that are forced to flee are often marginalized populations that have been persecuted. And so their living conditions in their home country will often put them at risk. So at risk of malnutrition, of trauma, of violence, etc. Then they make the journey, they're forced to flee, and they make a very difficult journey, often on foot, to a neighboring country. And that journey in itself puts people at risk. So they often don't have access to healthcare. They're living in very deprived conditions, often crowded. Sometimes they're put into detention in a country along the path. They're subjected to sexual violence, other forms of violence, and without any access to healthcare. So the journey itself puts them at risk of illness. And then once they make it to the host country, they're often, it depends on the country, there's variable conditions across the world, but oftentimes they're living in difficult conditions. So, I've worked in the Kakuma refugee camp in the past. This is a very large refugee camp in Kenya on the border with South Sudan. People there live in makeshift tents, in very crowded conditions, without access to very sophisticated care. They have very, very, very basic healthcare services, but very limited access to healthcare. And so their living conditions puts them at risk of things like tuberculosis, malaria, etc. And then they don't have access to healthcare, and so many of their illnesses go unidentified until finally they come to their permanent country. So a very small number of refugees will be resettled in a safe third country. That would be a place like Canada, and that's by far the minority of people. And when they come to Canada, they're connected to healthcare. And so that would be, they come to see a place like a person like me. And then we go through and assess their health and often identify their chronic health issues. So neglected chronic disease. So oftentimes people are diagnosed with, diabetes with complications for the very first time. Also various, in our children, various genetic syndromes that cause a whole myriad of illnesses. Malnutrition is another big concern amongst our patients. And then we help people navigate as well, because people, once they arrive in Canada, they can have their chronic and acute conditions identified. But oftentimes, if you're trying to access resources within the health system, so whether it's a specialist consult or lab or other investigation, it's incredibly difficult for our patients to navigate the health and social systems and even just the city itself. And so this is why across Canada, we have evolved to create services that are culturally safe for our refugees to meet the needs. And this is done because, yes, refugees, because of how we select them, we're selecting those with high medical needs. Because of their journey, we know that they're at higher risk of different illnesses. So whether it's trauma or infectious disease, so they have a higher burden of physical and mental health issues. But then they face, once they're in Canada, they face complexities in terms of healthcare delivery. So for example, they need a specialized clinic that can help them overcome some of the barriers they face in Canada. And that would be things like the language barrier. So they need services in their first language. So they need access to interpretation. They also need help of a health navigator. So oftentimes, things that you and I take for granted, how to fill a prescription, how to book a lab test or an X-ray or an ultrasound. For them, this is all new, and they're doing this through a language barrier. So they need staff, specialized staff, to help them overcome these barriers. In addition, as a healthcare provider, you're working through language barriers, cultural barriers, health literacy challenges, oftentimes, literacy challenges, digital literacy challenges. And so you as the physician or a nurse practitioner, you need a longer amount of time to spend with patients in order to address those complex health needs. And the fee-for-service system doesn't allow for that time. And so this is why across Canada, different refugee clinics have emerged with these specialized tailored services for refugees that enable refugees to both address their health concerns and also give people a bit of education and time to learn the health and social systems, as well as to navigate the actual physical environment of the city. And if you're ever curious to know where the different refugee health services are across Canada, we've created at the University of Calgary a refugee healthcare system atlas. And so it maps out the different health systems, the different health clinics available for refugees, as well as the resettlement services for refugees. And so the Mosaic Refugee Health Clinic, we were founded in 2006 by a resident. So he was a public health resident, and he recognized that the South Sudanese refugees were showing up in the emergency department with complications from illnesses that could have been identified and managed in the community by a primary care physician. And so what he did, he started to go into the resettlement center, and he would see newly arrived refugees and do their intake history, physical, and order screening tests. And then over time, this has grown to be the clinic that we are today. And today we're a fairly large clinic, so we're interdisciplinary. So we're 21 rotating family physicians with additional training in tropical medicine. We work very closely with our resettlement partner, which is CCIS in Calgary, and we have a nurse embedded within the resettlement center to address those immediate health concerns and triage their intake at the clinic. We have a very large interdisciplinary team that includes social workers, psychologists, nurses who really act as complex case managers, a health navigator to teach people how to book lab tests, book diagnostic imaging, get to their specialist appointment, get to the hospital, etc. We have a huge team of medical office assistants. We have public health nurses that come in every Friday to catch people up on their vaccinations. And then we also have a patient advisory committee. So in terms of developing our programs and services, we have a group of former patients who help us, who co-design programs with us and tell us what we're doing wrong, what we're doing right, and bring new ideas to the table as well. And in order to minimize the navigation barriers, we also bring in visiting specialists. So we have, a psychiatrist, we have 2 pediatricians, we have 2 obstetrician gynecologists, an internal medicine specialist, an infectious disease specialist, and a hepatologist with whom we do shared care. He never sees patients, but we review all of our hepatitis patients with him, and he helps us with the management, particularly treatment. And so over the years, it's really been, there have been many challenges since 2012. And those challenges have really impacted patients' access to care. And those challenges are listed here. We won't go through all of them. I'll just pull out a couple of examples of both successes and challenges. But starting in 2012, we were challenged with the cuts to interim federal health, which is the program that provides essential health services to refugees when they're newly arrived. The Syrian surge back in 2015-16, the Yazidi program, so the victims of Daesh. So this is a group of Yazidi women who were captured by ISIS back in 2014 and eventually released, and a group of them came to be resettled in Canada. The COVID-19 pandemic, of course, presented numerous challenges. And then since that time, we've resettled 40,000 Afghan refugees and hundreds of thousands of Ukrainian evacuees. And of course, this puts a tremendous strain on our health system. And so first, I'd just like to get into the funding cuts to the interim federal health program, because to me, in my naivete, when that happened, as I became medical director of the program, I found it very shocking. And it was the first time that I understood that policy actually has impact. So this program, so the interim federal health program, provides health coverage for refugees when they first arrive. So all types of refugees, asylum seekers and convention refugees. And it also provides coverage for essential medicine, basic dental, basic optical care. And this is just temporary. So typically it's for their first year in Canada. And under the Harper government, they cut those essential medicines, basic dental, basic optical for most of our patients, most refugees arriving in Canada. And they cut health services for a certain number of refugees coming to Canada. And so that had a huge impact on our patients, in terms of cancer care. It affected my patients could no longer receive cancer care. Our pregnant patients could no longer receive prenatal care without sort of being presented with a very large bill at the end of it. And so it created a huge inequity for our patient population, and especially in children. So there was a small study done at Sick Kids on the impact of the cuts on children. And what that study found was that refugee claimants who had their healthcare cut, they no longer brought their children to the emergency department for health issues. So they saw a decline or a decrease in the number of visits to the emerge. But for those who did present to the emerge, they were far sicker and often required admission, thereby costing the hospital more, right? Because the patients could never pay that bill. And so the cost would be assumed by the hospital. And so it had a negative effect on children, as well as many of our other refugees who could no longer afford their medicine, who could no longer get cancer care, who could no longer deliver safely at a hospital. And there's no greater investment in public health and children than by providing adequate prenatal care. And so I've had patients die because of this lack of access to health services. And so what did we do in order to combat these cuts and to advocate for health equity? Well, doctors across the country, we got together, we advocated within the media. We also partnered with the Canadian Association of Refugee Lawyers. The doctors provided affidavits, the lawyers sued the government in federal court and won. And the court deemed the cuts cruel and unusual. And so the government was forced to rewrite those cuts. And at the same time, what happened is there was an election, and what a difference an election makes. So with the Liberal government coming into power, they fully reversed the cuts. And then suddenly the world was right again. And so our refugees had their healthcare restored, but for some of the refugees, it was too late. So for example, I had one patient where he had hepatitis C, and he had developed liver cancer just before the cuts. Then the cuts happened. He couldn't get the treatment for years. And then when the cuts were reversed, it was too late, and he died of his metastatic hepatocellular carcinoma. So policy matters, health equity matters. Then shortly after the Liberal government came to power, it was around the time where little Alan Kurdi washed up ashore, and there was a huge public outcry in terms of wanting the government to do something for Syrian refugees. And so when the Liberal government came to power, they agreed to resettle 50,000 Syrian refugees to Canada. And what was about that was that there was a huge amount of public support, and it became a community project. It became a a country project to resettle the Syrian refugees, and they were truly welcomed with open arms. And all sectors at that time in Calgary and across Canada, the different sectors came together to strategize about how to best resettle and integrate the new Syrian refugees. And so in Calgary, we struck a large group together, and we would strategize in terms of how to best address their schooling needs, their health needs, housing needs, etc. And so I think that was an example of how to optimize health equity for newly arrived refugees. It had everyone together at the same table. The community was engaged. Syrians, when they arrived in Canada, they were welcomed. And just that, they were used to being unwelcome because they weren't provided a similar welcome in Turkey. In fact, they were discriminated against in many of those neighboring countries, especially Turkey. And so when they came to Canada and they were welcomed with open arms, that goes a very long way in addressing people's mental health issues. And so that was an example of when we did things right. And then with the Yazidi refugees, so they were resettled shortly afterwards in 2017. And the Yazidi refugees were small in number. There was only 1,300 brought to Canada, but they had acute issues related to their trauma because they were in captivity from 2014 to 2017 and almost immediately brought to Canada. And they faced many, many barriers because they were mostly women and children. Many were not literate in their own language. Some were innumerate, so unable to recognize numbers. Very traumatized without a welcoming host community. So there was very few in Calgary. There was no pre-existing Yazidi community. So they were the pioneers. They were the only people from their culture in Calgary, nobody speaking their language. It was very disorienting for them. And with the trauma, especially the trauma for the children, we knew that the trauma was not something that was going to resolve with a pill and some talk therapy. It was going to take something much, much more. And the trauma would present itself over a person's life course. So a child might be coming when they're 8 years old, but we know that during puberty, there might be additional symptoms regarding their mental health related to their prior trauma. So we needed to be prepared for that. And I knew that us as the refugee health providers, we were not going to be the ones seeing that. It would be others, either in the health community, but much more likely in the schools. And so how do we engage different sectors of our community to be able to support Yazidi women and children? And so to that end, we followed the Syrian resettlement playbook, which was to engage all sectors. But this time we also included the Yazidi themselves, because we needed some representation from their own community who could direct us in the right direction and be able to identify to us what their priorities were. And so to that end, in Calgary, we created something called Thriving Yazidi Futures. And so it included education, the city of Calgary, the different community associations, health, etc. And so we all came together, and the Yazidi members who participated, they were able to identify to us what their priorities were, and then we could work from there. And so that, I would say, is another great example of optimizing equity for a refugee population. And then, of course, then the pandemic came. And then with the pandemic, I think we've probably all read Theresa Tam's report, and we know that refugees were disproportionately impacted. So refugees are much more likely to be essential workers, live in intergenerational households, also work as healthcare aides in nursing homes, et cetera. And so they were much more at risk of becoming ill, and much less able to take time off work. And so they were disproportionately affected. And then with the rollout of the vaccine, we knew that they were much less likely to take up the vaccine. But as our premier said, it's because they don't want the vaccine, they're not accessing it. But we knew better. We knew that the problem wasn't their attitude towards the vaccine. The problem was access to the vaccine. So in Alberta, in the northeast of Calgary, which is where most of our refugees resettle, we had the highest rates of COVID, the lowest uptake of the vaccine. When we strategized to make the vaccine more accessible, so instead of having to log into an obscure website to book an appointment in English for the vaccine, which was only available during working hours, et cetera, we devised a barrier-free or low-barrier vaccination clinic in the heart of the Northeast. And so this we held over the course of the weekend. We engaged with community leaders. We provided community outreach and information ahead of the clinic. We provided interpretation on site. We created a bit of a festive atmosphere whilst respecting the boundaries of the time. And to that end, we had a very successful clinic. It was walk-in only, not appointment-based, et cetera. And so because that was successful, we then carried on by having other mobile clinics, vaccine clinics with cultural brokers, et cetera, at places where refugee and newcomer populations congregate. So whether that's the shopping center or the mosque or the church, it would just go around and provide vaccination. And in the end, we had the highest uptake in Canada. So we achieved over 99% uptake, which is unheard of. And this is in a community where the premier said, these people don't want it. They're hesitant. And so I think that's how you achieve health equity, is by designing a program to meet the needs. And you can only design a program to meet the needs as if you have representation from that community. So that was the lesson I had learned from the Yazidi, that you need to have them involved to the population that you're serving. You need to involve them as co-designers in the intervention in the program in order to achieve success. And I think COVID-19 proved that to us in the northeast of Calgary. And so this is simply, this is our clinic data. So over time, I've always thought that, my goodness, I'm always feeling completely overwhelmed because we feel like we can never catch up. And this shows that indeed we are getting busier. And this is only the data until 2020. And I know that since the Afghans have been resettled, it's been exponential. And so we as a little health clinic cannot do the work alone. And in order to achieve health equity, what my goal is to work myself out of a job. The way to achieve health equity for refugees, as well as to everyone, is to have the mainstream system be able to meet the needs. So we need to change how our mainstream system meets the needs of different groups, including refugees. And from my experience, the best way of doing that is to ensure that they're included in the design process. And so if there's a new service, if you're designing a vaccination program, for example, or a program for people with disabilities, that representatives from the community that you're serving need to be included to co-design that intervention or that program. Because we will not be able to meet the numbers. And what I have recognized over time is that the refugee biz is a growth industry. And so these individual clinics across the country, they're not going to be able to meet the needs of everyone. As right now, we're not able to meet the needs of the Ukrainian evacuees, for example, because hundreds of thousands of people can't be served by these relatively small clinics across the country. And so this is my question to you, is how can we safeguard equity moving forward? How can you do that in your work? I know that in Canada, in my work, it's never been linear. It's always been 2 steps forward, 1 step back. I'm currently in Calgary and we're moving in the negative direction because the government has cut our funding. So, you know, they've told us that by March 2025, we will no longer have operational funding for our clinic, in which case our work is not sustainable. We need that operational funding to be able to continue to serve the refugee population working in Calgary. So I still have a year to fight for equity for our patients. But my question to you is, how will you safeguard equity for refugees within the work that you do? And so I hope I've been able to give you a bit of an overview of refugees, the numbers of refugees and their context in the world and in Canada, the evolution of refugee healthcare in Canada, that health equity still has not been realized. We're moving in the right direction generally, but health equity has still not been achieved for our refugees and other newcomers in Canada. And that in all of our work, we need to always have that health equity lens in program design. And the best way to do that is through the incorporation of refugees as co-designers. Thank you.
Thank you so much, Dr. Coakley. That's a great presentation. It continues to strike me how many diverse communities are represented within the refugee community and how it's not a homogenous group, and how having folks at the table can really make a difference. We've got a couple of questions in the queue, and I encourage our audience members to type away their questions if they have them. So to get started, what are your thoughts on the kinds of services children from Gaza and their families might need as they come to Canada?
Yeah, that's a very good question. I imagine trauma will be very high on the list. And with trauma, like, we cannot help, like, what I've learned, because the Yazidi children were the most traumatized I've ever seen because they were used as child soldiers. They themselves suffered horrendous physical and sexual abuse. They witnessed it in their mothers. And that's the first time where I saw a large cohort of children having psychogenic non-epileptic seizures. And so that's a very severe manifestation of trauma. And the schools were the ones that called me like the teachers were crying on the phone because they didn't understand what was happening and they didn't understand how to manage. And it's actually a very difficult problem to manage, and it requires a team. And for us in Calgary, we were able to get, it was very ad hoc, specialized funding for the children with psychogenic non-epileptic seizures, where they actually had an OT attached to them at the school, and they had reduced work hours, and they'd have to do, because to prevent the seizures from happening, you could do physical activity to prevent it. And they also receive psychological counseling at the schools. And so I think for the children from Gaza, trauma will be one of their biggest issues. And in my perspective is the schools are the backbone of children's health, or mental health in particular. So they will identify the issue because it often comes out in different ways. And I find parents don't recognize it as a mental health illness that they need to see a doctor about. It's like, oh, my child is acting out, or my child just doesn't pay attention, or he's not good at school, or, they don't think of it as, oh, maybe this is a manifestation of my child's trauma and I need to see a doctor. They think they don't view it that way. And so they don't bring the child to see me, but the teacher will recognize it, and the teacher will access resources within the school system if they have that, or they will tell the parent, you must take your child to see a doctor about this and this and this, and they'll come with a little, like a letter from the teacher, and then I'll be able to help address it. But I think we need to help our schools prepare for those children in particular, because that will be a lot of work for them. And I think the schools are already under so much stress. But school is a mental health intervention.
Yes. Thank you. Lee asks if your clinic collects data that would address cost savings of what you do from a health promotion and care and treatment perspective, rather than sick patients going to the ER and being hospitalized, continuing to advocate for government not to cut the funding.
Yes, and so we just got linked. So we have our data. So we've collected our data. It's clean. It's in a database at the University of Calgary, and we just got it linked to the Alberta Health Services acute care data. So we're just in the process of doing that work.
Oh, wonderful.
Because I know it to be true. I know it in my heart, but that doesn't cut it. But the other thing that I've realized too over time is data doesn't always matter in terms of political choices. So, I have great arguments with the government. And I think, oh, look at all this research, because we do have a lot of research that shows, the pregnant patients that come to our clinic, they have the same outcome as Canadian women, which is unheard of in refugee health. So I know we're doing a good job, but I can present that to the government and they're like, these decisions are political. Data helps, but it's never the full story.
Yeah, it's one input into the system, and it really depends on their goals and other factors and competing priorities and lots of other things. We have a long road ahead of us from an advocacy point of view, and there's lots of folks in the room and elsewhere who are working very hard from an advocacy point of view, including yourself, no doubt. I want to thank you for your fight to restore the interim federal health program for refugees. Was probably no small task. Another question, in terms of risk, what do you feel that in the interim health program, is it under risk in the future as governments change?
I think so. I think it is at risk. I'm hoping that the government, I hope that they think, oh, those doctors were such a pain in my behind that they choose not to do it, because I think it was painful for them, but they never, I mean, like Jason Kenney never stepped down from his the cuts, you know, he never backed down. But I'm hoping the government remembers that it was difficult on them to have doctors doing sit-ins at their offices, etc. But I would say health equity is always at risk. Like that, to me, it was shocking. Like I thought, can this really happen in Canada, where we, and to be honest, it still happens in Canada because there are groups of migrants and others who still don't have healthcare coverage. And it's not good for patients, but it's also not good for our system. Like it's not good for the public health or even our system, because things deteriorate. People will eventually end up in a merge, but their conditions will be so complex at that time that they'll need admission. It costs more, da 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 da. Like I think COVID-19 taught us that you need to include everyone to optimize public health.
Yeah, for sure. Particularly in those infectious diseases, but not limited to those, in fact. Yeah. Are you aware of the proportion of children in Canada who are refugees?
Well, in our clinic, it's actually 50%.
Okay.
Like in our clinic, yeah. So that's just our clinic data where they're 50%. I don't know actually for Canada overall.
Child health and related data is certainly another gap that we should be advocating to address as well.
So globally, like the WHO and their Department of Migration Health, so this is what they're trying to do with the Second World Report, is to ensure that data on migrants is included in data collection, like in every national statistics. And Canada will be one of the initial pilots. So hopefully, so there's a huge data gap on migrants in general, and migrants in general are excluded from health systems. And so it's so important to have that universal healthcare coverage and collect data so we know what people are at risk for, and then try to address those risks, address the health needs.
Yeah, there's often a lack of data at the child level around socioeconomic status, around racialized, Indigenous, LGBTQ. So we don't know who we're serving as well or not.
Yeah, we're blind.
Yes. I want to thank you so much for a great presentation. There's lots of lovely comments in the chat box that we'll share with you later. And I just want to say that today we've heard from your program and from Dr. Nicole Catherine around British Columbia's Healthy Children Connections Project, the Nurse Family Partnership, and the Elizabeth Fry Voices Project. There's a lot of initiatives going on. We may need to sort of knit them all together to help us all row the boat in the same direction. And from today, I'm taking away sort of to summarize the day that child health equity from a health services perspective is all about meaningful engagement, all about compassionate care. It requires evidence from research and data, from clinical and policy settings, and from lived experience. It requires engagement from the start, even including preconception of programs and planning. It requires committed advocates like yourself and protection of the rights that currently exist and the access that folks already have. It requires political support, and that is not just a tick box. That requires a lot of effort. Adequate and sustainable funding, which is tied to political support. Needs and strengths-based approaches, creative models. removal of barriers to access, teamwork from a team-based primary care or a clinic like yours or collaborative care teams, intersectional, intersectorial collaboration, and data evaluation and research. There were a number of striking quotes that came through today that tell us language matters. It's need to reach, not hard to reach. Dr. Ripu Minhas reminded us that it's not people who fail, it's systems that fail. That policy matters, as you said, and health equity matters. And it requires attention and support. We need to address those barriers. Disparity is not recognized because often there's no sign to others of what disparity looks like. That was Karen Taylor. She also said when barriers are addressed, we get to the same destination, but each family may have its own path there, which is all about the tailoring of supports and services to various groups and individuals. And we can reach in to prevent kids from coming into the hospital in the first place, this upstream versus downstream proactivity and service delivery. There are better outcomes when we intervene before kids become unwell and as early as possible when kids who are vulnerable immigrate or are refugees to Canada. Refugee health means leaving no one behind, and there's no greater investment to children's health than to provide equitable care. I want to thank you, Dr. Coakley. I want to thank Dr. Nicole Catherine, and I want to thank all three of our concurrent session speakers. You shared your time and talent and expertise with us today, and we're so very grateful. Thanks to our audience for listening in. A half a day is a lot in a busy schedule. We really appreciate your dedication to this issue. And your comments and questions also enrich the discussion. I want to extend a huge thank you to our sponsors, the IWK in Nova Scotia, and our strategic partner, One Child, Every Child. This may be the end of our day today, but it's not the end of our series and these conversations and the important collective action that we need to take together. On March 21st, we're coming back for a focus on research in child health equity. And on March 28th, we'll gather again for the final part of this series, evidence-informed policymaking to advance health equity for all children. And we are hoping to continue post this three-part series to continue these important conversations and work together to ensure all children in Canada have equitable access to and experiences of care and equitable health outcomes. And to that end, we'd like to gauge your interest in joining a Canadian Child Health Equity Network. If you're interested, please complete the form at the link provided. Logan's going to pop it in the chat in a second. And finally, to help us improve our products, services, and events like this one, please take some time to complete the evaluation. I had popped it into the chat box earlier, but Logan will poke it in again. And we hope to see you all again here on March 21st. Thanks and have a great day.